Hi guys, welcome to my channel D.E.V, that is Daily-Endodontics-by-Viresh. Now today we'll be discussing about the principles of MACD. MACD is not McDonald's, but MACD here stands for Mandibular Molar Excess Cavity Design. Yes, that's right. We'll be discussing about the basic principles to follow in order to make an ideal mandibular molar endodontic excess cavity. Before we start making an ideal excess cavity and mandibular molar, let's learn some details that we need to know before we start doing this process. And these details are about the internal morphology of mandibular molars. Now, as we all know that mandibular molar basically consists of two roots, mesial and the distal root. However, they have three root canals, distal, mesiobuccal and mesiolingual. So this means that the distal root has one canal and mesial root has two canals. There is high incidence of finding a fourth canal which is called as the distal second canal. So when this happens, then the root canals are called as basically mesiobuccal, mesiolingual, distobuccal and distal lingual root canals. So therefore this means in these cases mesial root also has two root canals and distal root also has two root canals. So when there are three root canals in a mandibular molar, which are namely mesiobuccal, mesiolingual and distal, then the shape of the excess cavity is triangular, with the apex of the triangle towards the distal side and base of the triangle towards the mesial side. However, when we find the fourth canal, which is the distal second canal, then the shape of the excess cavity basically changes from triangular to a quadrangular shape with all the root canal orifices on the corners of these rounded quadrangular shape. There is a chance of finding a third middle mesial canal if we are using magnification. Researches and evidence has shown that many a times a middle mesial canal is often located. Now, whenever a patient comes to us for a root canal therapy, this means the pulp of the tooth has got irreversibly damaged either because of a deep caries lesion or because of a deep restoration. So in such cases, when the tooth is suffering from a deep caries lesion, it is always better to see the caries lesion in two parts, that is the peripheral caries and the central caries. We as clinicians are often in a hurry to jump into the pulpal space, whereas there is no need to do that. The patient is under local anesthesia, patient is under rubber dam, so there is no need to hurry. So it's always better to start with peripheral caries excavation first, because we need to provide a healthy environment to the tooth as we move towards the pulp. So when we are doing peripheral excavation, generally we use round burr to excavate the enamel and the superficial part of dentine in this phase of excavation. What we are trying to do is we are trying to give a sound periphery to the central part. At the same time, we are gaining access towards the central part. We are removing caries lesion from the peripheral part. We are removing all the unsupported tooth structure which is of no use or has become caries from the peripheral part. Once the peripheral part is complete, we need to examine with the help of a blunt probe or a DG16 explorer. But no force has to be used during this protocol. You can see in the video that I am using a round burr and it's a high speed burr. We just need to touch the burr on the affected part or the infected part and the burr will do its job. It's a diamond burr we are using. It will just do its job. We just need to brush the burr. And how we can control the handpiece is by using a proper finger rest. As you can see on the video, we are just scraping off, we are just brushing the peripheral part, and the peripheral caries lesion by itself is just getting scraped off with the movement of the burr, and that is what our intention is. Once this is done, we just need to be sure by properly examining the area with a blunt probe as I spoke earlier or with a DG16 explorer. Once we are sure the peripheral excavation is complete, this is the time when we move towards the central part. We are basically trying to narrow down the operating field, starting from periphery, going towards central caries excavation, and then finally entering into the pulp chamber. We are not in a hurry to do so, as I told earlier. Therefore, just keep on brushing the carious lesion until and unless you feel a drop or we enter the pulp chamber. What basically happens is when we are brushing, we are removing the tooth surface and slowly and steadily we are de-roofing the pulp chamber. Once the de-roofing happens and we feel we have entered the pulp chamber, stop at that point of time. We are not in a hurry to complete the excess cavity at this point of time, or even we are not in a hurry to locate all the canals, because probably our excess cavity is not complete at this point of time. So use a DG16 explorer or an endodontic explorer, both are the same explorers. Use this instrument to examine the peripheral extent of the pulp chamber. If we feel that we have decently extended the pulp chamber, at this point of time, we can go for location of the canals and see if we have orifices with us. However, if we find all the orifices, that does not necessarily mean that we have performed an ideal excess cavity. So therefore, examine the axial walls of your excess cavity. When we are moving our endodontic explorer from inside to outside, then our endodontic explorer should basically come out smooth. This means that the junction of the pulpal floor to the axial wall, the dentine and enamel should be in one line. Therefore, the axial wall should be smooth. So therefore, when we are moving our endodontic explorer from inside the pulp chamber to outside, everything should be smooth and our pulp chamber should be in one line. Axial wall should be in one line. But if our endodontic probe or endodontic explorer is getting stuck in some wall, this means that the wall needs to be extended because there is an overhang, and this overhang might not affect your endodontic treatment directly, but it can have an indirect effect because it will be a harbor to the remnants of pulp there, and which we might not be able to clean or disinfect with our irrigants. Therefore, it is important to remove this overhang which you can see on your screen, and the best way to do is use the same endo-Z burr, but take care that before using the endo-Z burr, touch the tip of the endo-Z burr on the pulpal floor as you can see here, and then lift it 0.5 millimeters and then start rotating it. Because if we touch the pulpal floor, then we are damaging the tooth structure here, which is not our intention. We just have to perform lateral cutting on the wall which is having overhang and bring it to a position where the junction of the pulpal floor and the axial wall are in one line. Once we have achieved this, taking care that we are not touching any other wall, because we already have a straight line access in each and every wall other than this present wall. Once we have achieved this, we just need to verify with the endodontic explorer that there is no more overhang present in the excess cavity. You can see here that verification is happening now, and once we have verified this, that we have a straight line access and we do not have any overhang present, the most important step right now is to perform pre-instrumentation irrigation. Yes, this is often a very ignored step, but this is one of the most significant steps in a complete protocol of root canal therapy. Never ever ignore irrigation. Devote adequate time which is required for a good instrumentation as well as good disinfection of the pulp chamber and the root canal walls. You can see here pre-instrumentation irrigation is being performed, and once we have performed the pre-instrumentation irrigation, if we are using rotary endodontic files, then every file system comes with an orifice shaper, or if you may call it as an orifice widener. What we have to do is we have to just fill the pulp chamber with an irrigant, never ever work in a dry canal. And you can see here that I just used orifice shaper. The intention is not to take this file till the working length. Please do not take this file to the working length, because it is not meant to do that. Just insert the file in the root canal till the point of resistance and start using it. The intention or the purpose of this file is to just widen the orifice. It is not shaping the canal, the whole canal, but it is just widening the orifice, because once you irrigate the widened orifice, lot of bulk of debris comes out, as you can see on the screen, and also the irrigant comes out in bulk. So less irrigant, extrusion happens in the periapical area, and we have enough evidence in the scientific literature. So after every instrument that is being inserted inside the canal, please use irrigation. Do not ignore irrigation. Yes, I am repeating this because I feel that irrigation is one of the most ignored steps. If we are not using any rotary endodontic file system, then we can go back to the traditional way of orifice widening, which is the use of Gates grid and drill, as you can see on the screen here. Only taking care that we choose the correct size of Gates grid and drill. We are not doing any outward to inside brushing movements. We are not forcing the Gates grid and drill inside the canal. Perform only circular movements and inward to outside brushing movements, and once they are done, then we go back to the use of irrigating solution, because this solution will help the bulk of the debris which we have just cut to come out of the canal and not block the remainder of the canal. Once the bulk of the debris is removed, then we can put a 10K file to check the patency. In case the irrigation needle gets blocked, or you feel that the irrigating solution is not going with the same intensity, we can change the needle, which we just saw here, and perform irrigation. Same protocol we need to follow for the other canals, as you can see on the screen. The second mesial canal is being orifice widened right now, taking care that the GG drill is not forced inside the canal, and at the same time we are only performing circular movements and inward to outside brushing movements. Once these movements are done, then the orifice is widened enough in order to receive the next following instrument, but only after irrigation. Do not ignore the irrigation step. Again and again I am emphasizing, because irrigation does magic. The irrigation dynamics does magic to the root canal system. Once adequate irrigation is performed and canals are absolutely clear, the time has come where we can introduce the first files inside the canal. Yes, the first files in general cases is the 10K file, which needs to be introduced inside the canal to check for canal patency. Often I have heard that we all face difficulty while negotiating the mesial canals, or while placing the files inside the mesial canals of mandibular molars. We can use a locking tweezer to hold the file. We can pre-curve the file, and while inserting we can take care that the pre-curved part of the file faces towards the mesial side, so that we don't have to angulate our hand inside the throat of the patient. Therefore, we can just, by following these steps, we can straight, without using any force, place the file in the mesial canals, and once the file is placed inside the mesial canals, we can just adjust our visibility for the distal canals and place the files inside them. Once the canal patency is checked, we are ready to go for working length determination, cleaning and shaping, and subsequently successful obturation. So with this, we come to an end of this video where we have seen how to make a straight line access in a mandibular molar. I hope this will help all of us to guide how to make a access cavity, a straight line access cavity in a mandibular molar and clear many doubts. Thank you so much guys for coming over to my channel Daily-Endodontics-by-Viresh and spending your time, devoting your time and seeing this video. If you have any queries, any suggestions or any desired topics where you would like to see videos, please leave your comments in the comment box below and I shall take care to address each and every comment. Thank you so much guys for your support, and with this we have come to an end of MACD, that is mandibular access cavity design. Thank you so much. Have a nice day and see you soon.